Good evening, everybody. It's a pleasure for me to be here with you, and I'm very grateful to BMJ for giving me this opportunity to share some thoughts on the topic that I've been given. And I shall be talking about anxiety and depression in primary care. And at the outset, I'd like to say that I've been a practicing clinician, a mental health specialist, and a researcher with a special interest in evidence-informed health decisions. And I'm not aware of any competing academic or financial interest pertaining to this presentation. The learning objectives I thought we could go through briefly was first to figure out how common anxiety and depression are in primary care, and the reasons why these are underdiagnosed and undertreated, and what the consequences are of not recognizing and treating depression and anxiety in primary care. And we can briefly look at the risk factors and potential comorbid conditions that complicate our diagnosis and also give us some idea of understanding as to how we could manage these conditions. Then we'll talk a little bit about how we make these diagnoses and what are the screening tools that we could use. And then we'll look at some of the strategies for effective and integrated care. Now, I'm aware that this is a short period of time and I cannot do full justice to the topic, but I hope this will whet your appetite and we can have some discussions at the end. There are some caveats. This is mainly about depression and anxiety in adolescents and adults, because I'm not a child psychiatrist and my expertise does not extend to treating children. And I also want to emphasize that the topic is titled primary care, which normally denotes healthcare provided in the community at the very first point of care. But considering the situation that we have in India, it could very well mean that the very first point of care could be subsequently in the pathways of care. So I'm covering what might be happening and the kind of presentations you might see. You might recognize some of this. For example, there's a 30-year-old single male businessman who's a non-smoker. He's been complaining of acute episodes of chest pain over the past few months, and his father had died of an acute MI 4 years ago. He's had multiple visits to the emergency department. There have been non-specific ECG changes, so they've investigated him quite a bit, but all of these are apparently normal. But these episodes continue to occur. And he comes to you saying, I want a coronary angiogram. Not an unusual presentation. And at the end, we can discuss your thoughts on this. What additional history, examination, or tests will help establish the diagnosis? And what is the most likely clinical diagnosis? And what would be the management options in a primary care setting? Another common presentation is, for example, a 45-year-old married woman who's under your care for treatment of diabetes, hypertension, and occasional asthma. And normally her daughter brings her to you for treatment. But about 6 months ago, her daughter had to leave to go abroad to join her husband. And when she comes to see you now, she says her sugar, you find that her sugars and her BP are now elevated. She's complaining of incessant backache, tiredness, and she's virtually bedridden. And her asthma is also worse. So the same questions here. What additional history, examination, or tests will help you establish the diagnosis? What is the most likely clinical diagnosis? And what would be the management options in a primary care setting? So we will discuss this at the end, but let me just start by giving you some kind of a conceptual framework of depression and anxiety in primary care, and what are the issues that we are dealing with. First of all, we all know that depressive feelings and anxious feelings are normal emotions. They're part of the human's physiological adaptive responses to our environment, where when we sense any threat or danger, our body kicks in and gears us up to deal with the danger. And those symptoms, the autonomic symptoms, are what we perceive and reinterpret as anxiety. And this has a useful role in normal adaptation because that anxiety urges you to perform, to do something, to overcome that perceived threat. But anxiety can also become too excessive, and there is a relationship between optimal anxiety, where a certain amount of anxiety brings out the best in you, but if it's too much, it actually impairs your performance. So that's the normal role of anxiety. Depression is also an adaptive feature where the human organism adapts to losses or certain conditions where the body has to kind of withdraw from the stresses of life and recover so that they can go back into society. So these are normal functions. But when does it become a disorder? In mental health terms, they tend to call these conditions disorders when they cause significant distress and dysfunction to the person experiencing it and sometimes to the people who have to live with that person. Now, this also need not be considered a disorder unless it tends to be persistent, lasts for a certain period of time. So there is a problem. How long should it be there? Because very often disorders involving depression and anxiety could be transient. They could be self-limiting. So this is one of the conditions we have to keep in mind. When do we decide this is something that's persistent? The third thing is we make a diagnosis of these disorders, anxiety or depression, based on a constellation of typical symptoms, which we characterize into a syndrome, the syndrome of depression, the syndrome of anxiety. And we tend to, in clinical practice, because we have to act to treat, we tend to treat them as discrete entities. If you have this many symptoms that have lasted for this much period of time, then you have this disorder. But the problem is, if you look at clinical practice, especially in primary care, you'll find people who've got depression, anxiety, and a whole host of other symptoms. So there are people who tend to think that what we've done is taken these mood changes which are clear on a dimension, multiple dimensions, and for our practical convenience, we cut them off into discrete symptoms. From here to here, if you have these, you have a disorder called major depressive disorder. But the actual fact is, the majority of people that you see in primary care are a heterogeneous group of people who have a mix of various symptoms. And the other issue is you see a person for a period of time, depending on how much time you can allot that person. You only get a cross-sectional snapshot of that person's life. But to really understand the context of what this cross-section is, we need to also consider a longitudinal perspective. What does this episode mean in the context of the person's long-term trajectory of his life? Why has this person come to me now? He's had lots of problems, but why now? Why has he sought help now? That will help you to understand that what you're seeing is only a small snippet of what that person has been experiencing. The third thing is when we try and look at the etiology of what caused this problem, it is common for us to look for reasons. And it's also very common for patients to try and understand why are they going through what they're going through. And very often, when we see that there are stresses or there are particular antecedent events, we tend to automatically consider that this could be because of that. But there is also another dimension that certain people have certain vulnerabilities, biological vulnerabilities, genetic vulnerabilities, neurophysiological vulnerabilities, which that environmental event could work on that person to cause the person to tip over. The tipping point could be the event. Other people may not have that threshold to tip over, even though they have similar life stresses. So eventually we tend to think of it in primary care as a multifactorial condition. There are a constellation of biological factors which increase vulnerability, and there are environmental factors which, if they are significant enough to the person experiencing it, and they don't have the support systems or the coping mechanisms to deal with it, they could end up seeking help. So what we're really doing is we are classifying help-seeking behavior as treatment worthy. But we must keep in mind there could be a lot of people who suffer in silence at home because they don't understand what's going on in their lives. The next thing is we tend to look at people, and especially in academic circles, we want to see whether there are subtypes of these conditions of depression. Like, are there people who've got more symptoms suggestive of a biological depression, like melancholic features? Or are there people who've got psychotic symptoms, which means that they have definitely got some biological reason why they're presenting with depression? Even with anxiety, there are people who have got pervasive anxiety. They're just chronically anxious. They tend to worry a lot. And there are people who have discrete episodes of increased anxiety, thinking as well as cognitive, as well as physiological symptoms, which they present with, and they may not have anxiety in between, unless they're worrying about, will I have another attack? And there are people who have a different kind of anxiety, which is more internal, that they tend to ruminate about whether things are clean or things are in order or things are checked. So we try and see in the entire spectrum of people who present with anxiety, can we look at certain clinical subtypes? So that's the other issue we have to deal with. And then when we want to make a diagnosis, we've got to ask ourselves, how do we decide the person has moved from normal reactions to a disorder? Are there any ways that we can screen in terms of the kind of symptoms they have, the number of symptoms, the frequency, the intensity? What is the cutoff we should use? And then are there any criteria which we can say, if you have 1, 2, 3, 4, 5, 6 of these symptoms which have lasted for this period of time, can we say you have this problem? So then we have to ask ourselves, how reliable are they in picking up people who actually have conditions which need to be treated compared to things which may just go on their own? And finally, when it comes to treatment, there are a lot of effective treatments. They could include medications of various sorts. They could include psychological approaches to reframing and helping people improve their coping skills. There could be social issues which can be discussed. It could be cultural factors, lifestyle changes. So we have to make a decision as to what are we going to use and in which situation. And then there's a question of, we treat them for their acute symptoms, but what if the symptoms recur? What do we do when we want to prevent it? So this is a whole range of issues that we have to confront when we're dealing with depression and anxiety. One of the other things that we use is that we say there are certain symptoms and conditions which are very rare. It's not very common in life. And the presence of those symptoms indicates a serious prognosis. So, for example, if you have a person who's got, organic brain syndrome, he may present with confusion. He's really disoriented and he has visual hallucinations. He could be extremely forgetful and confused, so delirium. Now, these symptoms are not common and they denote a poor prognosis. They denote increased mortality and increased morbidity. So whenever we find a person who presents with anxiety or depression, but he also has these symptoms, we don't look at the anxiety and depression as a primary diagnosis. We try and find out what is the actual reason for this entire constellation of symptoms, which includes confusion and hallucinations. Similarly, when you have psychotic symptoms like hearing voices or believing that people are after you, getting paranoid, that's not as common as just being anxious. So those symptoms tend to have a greater weightage in saying this is not entirely just anxiety, it's something else. The problem is when it comes down to depression and anxiety, it used to be thought, and it probably is still true, that if a person presents with a mixture of anxiety symptoms and depressive symptoms, one should first start asking yourself, could the anxiety symptoms be part of a depressive disorder? Because that's not uncommon at all. And then consider whether the treatment of the depression would get rid of the anxiety as well, or would it leave residual anxiety symptoms which you need to look at separately? Fortunately, a lot of the treatments for depression and anxiety are very similar. So that's a good point. And then below that are these personality traits which vary from person to person. They may or may not be as significant in terms of immediate outcomes, although they of course shape how people respond to treatment. Now, how common are these disorders, anxiety and depression, in primary care? Now, there's a lot of research to suggest that anxiety disorders are very common, with a lifetime prevalence ranging from about 5 to 25% in populations surveyed worldwide. Now, if you look at the 12-month prevalence, it still is pretty high, ranges from 3.3 to 20.4. The sad thing is that less than 50% are diagnosed in primary care, even though the vast majority of them first present to somebody in primary care. And less than half of them, when they're asked, do they think they need treatment, say they actually need treatment for their anxiety. And only 25% of these people who are diagnosed receive any treatment, and only 10% receive treatment which would be considered to be adequate. And this is, of course, much worse in low and middle income countries. So these are figures from the Global Burden of Mental Disorders and the Mental Health Surveys. And they are pretty robust estimates to say that anxiety is pretty common and it's undertreated. Now, if you look at depression, in 2010, it was the fairly common, it's a very prevalent condition, the 19th most common disease in the world in 2010. But it was the second leading cause of years lived with disability. It causes a lot of dysfunction. And if you look at recent re-evaluations of these surveys, around 5% of the world's population had depression in a 12-month period. Around 50% reported that they need treatment, more than just anxiety. But this is much less in low and middle income countries. And if you look at the prevalence of depression, probably because of better reporting, or maybe there's more stresses, the surveys show that there's been an increase in prevalence around 18% between 2005 and 2015. Now, if you look at how many people get treated, it's a really dismal statistic that only 1 in 5 people in high and middle income countries and only 1 in 27 people in low and middle income countries receive what would be considered minimally adequate treatment. So there are a lot of people who suffer with anxiety and depressive disorders who are not really aware that this is a mental health condition which has some kind of effective treatment, and their clinicians don't really recognize to be a treatable mental condition, and they end up with problems. Now, if you look at depression itself, it can occur at any age. Even children can have it, infants can have it in different ways. They manifest, but commonly you see that it starts in late adolescence and early adulthood. So that's one big peak. And then the next big peak is around middle-aged. So you have two peaks when you have depression. One is when you're an adolescent or young adult, and the other is when you're middle-aged. And it's much more common in women than it is in men. And there are various reasons for it, which are partly endocrine, biological, but a lot of it is socio-cultural, the roles that women have to take. And there are various reasons for why depression and anxiety are underdiagnosed and undertreated. The first is at an individual level. Even if a person, the language of depression is very funny. Even though we call it depressed, a lot of people who have been through a depression don't necessarily feel sad. They have a lot of other symptoms. A lot of it is a physical, a sense of physical being unwell. And even if they're aware that what they're going through is what is depression, there is a stigma in society within their own minds, as well as what they perceive other people would think of them, their family members or their work colleagues. And also there is a difficulty in accessing care. And also when they go to see a doctor, their general practitioner, they're not very sure that this person is really interested in emotional issues. As far as clinicians are concerned, even if they pick up that there's something going on in their patients' lives, they are able to find lots of stresses which they think, oh, this is understandable. And a lot of the time it may be understandable, but they may not really be aware that even legitimate stresses can cause people to decompensate and end up with a depressive syndrome which needs treatment. So the combination of the two is they end up discussing physical symptoms because that's what they're competent at doing, comfortable at doing, and what the patient feels is what the clinician wants. And then there, of course, are all kinds of organizational facilities. You go to many of our PHCs, you find many of them don't have the medicines, they don't have the knowledge, and they worry, many clinicians worry that if they are seen to be treating people for psychiatric conditions, other people will not come and see them. And they don't have that facility of integrated care where they can call on mental health specialists to help them with this work. So one of the reasons why there's underdiagnosis is that in primary care, both anxiety and depression often presents as physical symptoms. Unexplained physical symptoms is the chief complaint for many people who present in primary care. And there are many, many kinds of symptoms they can have: abdominal pain, constipation, backache, headache, joint pains, neck pain, tiredness, weakness, forgetfulness, you name it. Any of these symptoms you investigate, and the fact is when you start investigating, it gives the person a feeling that you have taken this physical symptom seriously. So you've investigated it, And if you find that there's some abnormality in the investigation, you investigate further, and this further reinforces the person's belief that they actually have a physical problem. There are also other things to keep in mind, that depression and anxiety are very comorbid in people who have other conditions, other physical conditions. Like, it ranges from around 5 to even almost 50% of people who've got various kinds of physical illness can have depressive and anxiety symptoms, which are linked partly through a biological mechanism, partly through the medicines they take, and partly through the reaction to these conditions. Anxiety and depression is also a very common thing. There are various kinds of anxiety situations: episodic anxiety, like panic disorder, generalized anxiety, which is more persistent, or it could be just anxiety in specific situations, like in social situations where people feel awkward and shy and very introspective of what other people will think of them. Or it could be people who've got obsessive compulsive disorder, or people who are reacting very badly to memories of past traumatic incidents. Quite a few of them are going to end up with having depressive symptoms. So you could have people who are depressed, but they also have any of these other psychiatric conditions. And there are many other comorbid conditions we should think about. Prescription drugs can cause depression, can cause anxiety. Substance use disorder, like drug abuse as well as alcohol, is known to be associated with these problems. And any of these conditions increases the likelihood of depression being there. So we need to keep in mind that these are all things that we have to look for in people with drug abuse, anxiety, whether they have, and physical conditions, whether they have depressive or anxiety disorders. And this comorbidity increases poor outcomes, makes the conditions more chronic, increase healthcare usage, prolonged dysfunction, decrease adherence to medication, and eventually increase morbidity and mortality. And this comorbidity, as well as underdiagnosis, can be a consequence of being undetected. The other key to keep in mind is that depression, and to a certain extent some of the anxiety disorders, are a major risk factors for both attempted and completed suicide. And most people who attempt or think of suicide may have talked to their primary care provider, or come to them thinking that they want to talk about it, but have not done this. So this is another important consequence of having depression and anxiety. So there are a whole host of psychological, social, cultural, and genetic risk factors for why a person can say depressed. So I don't think that we can say that any one single factor can cause it. There could be a genetic vulnerability, although in some forms of depression it is not very heritable, whereas in others it is highly heritable. There are gender-related issues, there are cultural issues, and many of these factors all work together to actually cause people to end up with what we call syndrome of depression or anxiety. Now, one of the things we have to ask ourselves is, when we want looking at people, is what are the ways we can figure out whether a person is this person likely to be at risk for suicide? If they've got a depressed mood and you feel that they are, upset enough with their situation, we need to see whether there's been a past history in some family member who has committed suicide, or if they themselves contemplated or attempted suicide in the past. You must think in terms of if they've got access to methods which are considered serious. For example, in the West, one of the questions GPs ask is, if he's a farmer or if he's a person who lives in a rural area, they would say, do you have firearms at home? I suppose in the US these days, it could be everybody. Psychiatric diagnosis, particular diagnosis, increases the likelihood of suicide. Substance misuse, any chronic physical. So many of these are the risk factors we've got to keep in mind that increases our concern that the person might attempt or commit suicide. But we also need to talk to people and find out from them what are their supportive systems. If a person has got some support, someone they can confide with, if they have religious beliefs that they think that this is wrong, and they believe that they can cling to their religious hope, they would get better. If they are people who generally have a positive self-esteem and have a good job history and effective coping skills, and if they have access to care, these are all factors that mitigate against them actually committing suicide. Now, when you want to try and screen and diagnose them, we need to know what are the various diagnostic criteria that people use. Now, currently, there's a major depressive disorder, is a DSM-5, Diagnostic and Statistical Manual term. And there's an excellent review in the BMJ, which gives you a good way of screening and depression and diagnosis in primary care. And the most important cardinal symptoms are at least a depressed mood or loss of interest and pleasure. So when we talk about depressed mood, as I said, not many people may say, I feel sad, but it's like generally a lack of interest, a lack of, the usual ability to cope, and a sense that, life is flat. And the way we can elicit this is to find out whether there's been a change in recent time in the way they do their normal pleasurable activities. And then whether this is a transient thing or whether it's there nearly every day. Because that's what you'd expect in a person who's going through a major depressive disorder of some severity. You can also find other factors which are related to their body, their biological functions. So it could be that their appetite is low, is poor, and they lose weight. It's not a small amount of weight, it can be quite a bit. Or their appetite can increase. Some people tend to eat when they are depressed, so there's an increase in weight. There is often disturbance in sleep. For example, they may have difficulty falling asleep or staying asleep, but commonly, if it is a more biological kind of depression, they tend to wake up early, at least a half an hour, 1 hour, even 2 hours earlier. So you have a lot of people who get up at 3 in the morning. They are very, very depressed because there's often in this sort of melancholic or biological depression, they tend to feel worse in the mornings and they get better as the evening occurs. So these are melancholic features. But even if it's not there, if a person wakes up consistently, more or less waking up earlier than they normally do, and they don't feel like doing anything, they lie in bed and they ruminate about their situation, that's a sure sign that the person has depression. And sometimes you find that they complain of being slowed down, because when you have a depressive disorder, biologically your body metabolism slows down. And you can end up with constipation, you can end up with, thinking is slow. Or on the other hand, if there's a lot of anxiety with it, you can feel quite agitated and restless. And it can be seen by people that this person looks more anxious and agitated than normal. The other symptoms that you have to think about are the mental symptoms. So generally there is, when you get to a depression, there is what people consider a triad of negative thinking, where you can tend to consider your present as terrible, your past as terrible, and your future as hopeless. And there's a sense of feeling worthless or inappropriate guilt, which you tend to think of yourself as you've done nothing good in the past, you're useless. And you'll also find that you are not able to concentrate, you're very indecisive, you feel lack of confidence. And all of these end up with you starting to think that, life is not worth living. I'd like to just escape from this. And this can progress to where you actively start thinking in terms of ending your life. So these are the common symptoms in a person who's got a serious depressive disorder. But you have to make sure that this is not due to substance abuse. You must look out for those medical conditions, and you must also look out for other psychiatric disorders, because depression could be part of those. And more importantly, we must consider the possibility that this person doesn't have just a depressive disorder, but has a condition called bipolar disorder, where that's a more recurrent condition, where you can have the opposite of being depressed, a manic episode or a hypomanic episode. That is very important in primary care, because if you're going to deal with a bipolar disorder or a potential bipolar disorder, that's an indication to refer people, because that's difficult to manage in primary care. The international classification ICD-11 also has very similar symptoms, not that different. There's a lot of congruence. And they tend to look at this in terms of severity, which means that depending on how many symptoms you have and how much dysfunction it causes in your life, you can call it mild, moderate, severe, or conditions like that. It could be a single episode or it could be recurrent. In a lot of people, it could be just a single episode, but in many people, it can recur over their lifetime. Now, if you want to rule out hypomania, you got to ask for these symptoms. These are the symptoms of mania or hypomania. So it's more difficult to elicit those symptoms because people come to you with depression. They may not go to anyone if they've got a hypomania, subthreshold manic symptoms. But you may be able to piece together from the history, there are periods in time where they report that they were, thinking much more fast and they were talking a lot, they were spending a lot of money, they were more confident, and they were, and all their relatives may tell you there are periods in his life where he is very active and he does a lot of things, he spends a lot of money. And this is exactly the opposite of that. So we should ask for a history of hypomania. Now, anxiety disorders, there are various kinds of anxiety disorders. The general anxiety disorder is the most common, and it's constant feeling of worrying or muscle tension or a sense of restlessness. Or you could have a more specific kind of disorder, which is social anxiety disorder, which generally starts fairly early in life, but in many people it may get better as they grow on. Basically, you may be quite well when you're in school, but as you start becoming an adult and realize that there are people who will judge you, you become very anxious about your performance, of how people will think of you. And you try and avoid being scrutinized by others. And it can end up with you avoiding social situations completely. I can discuss that in more detail if people want to know more about it. Panic attacks are acute episodes of intense anxiety in your mind, thinking that something terrible is going to happen to you, accompanied by a lot of autonomic symptoms, such as palpitations, tiredness, weakness, your abdomen feels, you can have difficulty breathing. So these can be quite disabling for people. And if you want to know how to deal with that, we can discuss that as well. Agoraphobia is a kind of a unrealistic fear that of being in any place where they feel they won't be able to cope. It may be associated with panic attacks or it may not be. But the core features are that you've got an unreasonable fear of any particular open place or crowds, and you tend to avoid it. And you realize it is unrealistic, but this avoidance defines what agoraphobia is. Now, when you're screening for depression, one of the things you can do in primary care is just ask two questions specifically. This is taken from the Prime MD. There's a larger screening tool. But these two questions have got a lot of ability to pick up people who have depression. During the last month, have you often been bothered by feeling down, depressed, hopeless, or you had little interest or pleasure in doing things? Now, these questions are quite good. If you have both together, there is a high chance that this person has depression. But you need to have one more question. Would you like help with this? Because if you add the third question, would you like to have help with these problems, then you reduce a lot of false positives. Because if you don't ask this person, do you want help? Often people could be going through some problem in their life, but they don't need your help for it. That may not be a major depressive episode. So these are two screening questions you should keep in mind. And in anxiety also, there are similar questions like, do you constantly feel anxious? And would you like help with it? So then you can go and look through whether they have all the other symptoms of depression or anxiety. So the screening questionnaires that you can use, the common ones that you can download this from the net. It's a patient health question. It's got 9 items, and a score of 10 or above suggests that this person is depressed. So the way you would do that is you use a 2-item question, that is these 2 questions we talked about with the ancillary question of do you need help? And if you think, yes, this looks like the person can be depressed, you can go and ask the other questions on the patient health questionnaire. There are various other questionnaires for depression as well as for anxiety, but this is a good way of doing it. When you want to look at treating conditions like this, the BMJ has got a beautiful paper on how to manage depression, kind of a stepwise approach. So the very first thing to keep in mind is that if you've got a low-grade sort of depression with just symptoms of, you have some of the symptoms, but you're still functional. The what people suggest is that you wait, active waiting. You look to see whether a person's symptoms are getting better or not, and you help people improve physical activity, any kind of physical activity in a graded manner, which they can be supported to do, because physical activity is excellent treatment for low-grade depressions, mild depressions. It could be anything that, including just walking, running, and also guided help into structuring your life, finding, some pleasurable thing to do, little by little, stepped care, and guide them through to see whether this will go away, right? Self-help books can help people, and there is an excellent book which I often recommend to people. It's called The New Mood Therapy. You can just Google The New Mood Therapy, and you'll find it's available on Amazon. It'll help you also to understand some of the cognitive thinking that happens with people who go through depression. If you start finding that a person is not improved in a couple of weeks, then you can start adding other therapies. And one of the practical therapies you can use in low and middle income countries is problem solving. It is to actually try and figure out what are the current problems that people are going through, and look at all the reasons why it could be there, and think in terms of what are the factors that could be contributing into it, and what could be potential solutions. Help people to brainstorm and pick on priority problems that they can actually deal with. This has been shown to be reasonably effective in primary care, although it requires you to build up a good relationship with your patients to say, let's just focus on the current problems. There are various other kinds of counseling, support, behavioral activation that people can do. And for moderate to severe depression, you'll have to start thinking in terms of whether we want to add an antidepressant of some sort, or add, in the West, where there are many psychological therapies available, there's interpersonal therapy, which is a more focused look at the interactions that people have with others in their lives and the significance of those interactions in helping in creating the problems for them. So the antidepressants are the mainstay of treatment for both anxiety as well as depressive disorders. Anxiolytics are very commonly used in clinical practice for anxiety, and unfortunately that's not the best treatment because they tend to be addictive. Antidepressants have a lot of anxiety, anxiolytic effects, and there are a whole host of antidepressants available in the country, and all of them have some ability to reduce anxiety. So instead of using, benzodiazepines as a mainstay of treatment for anxiety, consider using antidepressants because they are found to be much more effective. So the commonly used antidepressants, which is citalopram is not available, but escitalopram and sertraline and fluoxetine. These are the ones that you should consider familiarizing yourselves in terms of the doses and the effective treatments for this condition. Venlafaxine is another drug that is used, but it has a lot of problems in terms of acute withdrawal effects, and it can also cause hypotension. So we need to be careful. Mirtazapine is another very safe drug to use. It depends on whether you want a person wants to be asleep, he wants a sedative effect, you could use mirtazapine. That's quite good, and we can discuss that more. So when you're looking at progression of depression, one of the things that people in hospitals use is the Hamilton Depression Rating Scale. Now, if you're looking at that kind of a symptom, you're basically asking yourself, compared to when the person first came to see me, is a person better? So in clinical practice, you just need to ask people, compared to when you started off treatment, how much better are you? And they will tell you, generally my patients will tell, I don't use any of these scales in primary care because it just takes too much time. Much more simple to ask a simple question, how much better are you? And people will tell you, I'm much better. So we try and get them to quantify it. Many of our patients will tell you, I'm about 50% better or 75% better. So what people have realized is, compared to before, if they are 50% better, they feel that, and you are able to agree with them on it, it shows that they are shown a treatment response. But if that does not completely go away, that is an indicator for you to consider increasing your dose to the maximum dose, which you need to keep for periods of time. The other things that everybody who goes through these conditions will need some degree of talking therapy. So depending on how serious the person is and how much skills you have in giving all these treatments, you could use various things. But trying to solve their current problems in a problem-solving supportive approach is the best that we can do in our busy clinical practices. And it's good to be able to look and try and get people to think about saying, I know you feel suicidal, for example, but just help me out here. I'm going to help you. And in about 3 to 4 weeks, if you still feel suicidal, I can't help you, but I'm going to try and help you not to feel this. So we get them to make a contract with you. And then the other thing that we can do is try and help them to understand that what they're going through is a legitimate condition. It could be something which has got a physical part of it, and it could also be something that you are trying to, overcome. But it can be something that we can work towards. And we try and explain, why is it you feel like this? Why do you have this problem? So I find that when I ask patients, do you have this condition? They say, well, he seems to know my condition. He seems to know what I have. And the other thing to keep in mind is that you need to tell them that you need to take your pills for your treatment, for your problems, but sometimes you may need to talk about how this episode of depression or anxiety is, what is it doing to you? So we need to be able to integrate this as part of their lives. And there are many other things that we can discuss, but out of shortage of time, I will stop. I'm happy to take questions. Thank you.
Thanks a lot for your excellent presentation, Dr. Pratap. I will just start with the already submitted questions, then we can go for the live questions. Shraditya from Bangalore has asked, what is the emergency management of sudden anxiety?
Okay, so when a person comes to you with anxiety, one of the things that you're trying to rule out is acute panic, a panic attack. But you also need to make sure that there's no other physical problem which is causing them anxiety, which could be your clinical work that you do. But if you feel that, I think this person is like the guy I talked about in the beginning who has chest pain. He keeps going to emergency side for chest pain. Now, if for him, we need to be able to help him to if it's very, very, very anxious, two things that we can consider doing is, one is give him a short-acting benzodiazepine like alprazolam, which will act pretty fast. And the other is to help him to learn how to breathe. Calm down, breathing. So which means the breathing exercise, ask him to hold his chest, take a deep breath, let it out. Because what happens when you get very, very anxious and out of panic, you tend to hyperventilate. And that causes a problem. Then when he calms down and we want to help him, there are two things we can do. One is consider giving him a small dose of escitalopram. And when you're starting an SSRI, you've got to start small in people with anxiety disorders, because sometimes these SSRIs can hyperstimulate you. So you give them a small dose of 5 milligrams of escitalopram. If temporarily you can continue the alprazolam or lorazepam or a short-acting benzodiazepine, and then start thinking in terms of helping to understand why is it happening. Sometimes it's spontaneous. There's no reason for it. But in this gentleman, it could be that his dad died of a cardiac illness. And in the actual patient that I saw, he said, one of my close friends got admitted with chest pain. So then what he started doing is thinking in terms of, oh my God, I should also be at risk. And then his mind started focusing on his chest. He's constantly policing his chest. For example, none of you are aware of the fact that you have a thumb in your right hand. All of us have thumbs, but we are not aware of it consciously. But now that I pointed it to you, mind will focus on the thumb. And if you have some concerns, so what he was doing, he was policing his chest. So we tell him, explain what's going on in his life and help him to divert his mind from these situations. So those are the kind of things you can do for acute anxiety.
Thanks. Next question is from Anju Huda from Delhi. What is the role of grassroots level workers like community helpers, health workers, ASHAs, etc. in detection and management of mental health issues?
Yeah, fantastic role. In fact, there's a Cochrane systematic review which talks about this. Lay health workers are fabulous at being able to detect and to liaise with treatment services. In fact, if you go to the WHO website, there are many documentation which talks about training. How do you train people to, lay health workers, grassroots workers, to recognize the symptoms of depression and to treat them? I think they are essential, because what happens is that people are not so, the stigma is much less. They can talk to you. You can establish a connection at a more human level. And if you know how to ask these screening questions, you can pick up depression very easily. So it's good to have a program that includes lay health workers and even psychologists, for example. Psychologists should be able to attach them to practices, general practitioners, so that they can then learn to take on referrals for people who have anxiety and depression.
Thanks, Dr. Arya. Let me go to the next question. The next question is from Rajiv Kapoor from Mumbai. The question is, 26-year-old son with anxiety and depression refuses medication. Can we consider medicating without his knowledge?
I mean, this is a common problem that we all have. Now, if it is just anxiety and depression, the first thing to do is to establish a relationship with the person. And if the person is concerned that he's going to be drugged and treated for it, it means that we have to be able to help him, saying, okay, let's try a stepwise approach where we first ask you to do things which can help you to get better. I would not consider, coercing a person with an anxiety disorder or a depressive disorder to take treatment unless they're at serious suicidal risk or risk of harm to others. It doesn't work in the long term. So we need to understand what is the meaning of this whole treatment for that person. So in general, if you can get, a good rapport with the person, if it's only an anxiety disorder, if it is something else, that's different.
Thank you, Dr. Arya. Next question is from Bangalore, from Nishank KP. How do we deal with burnouts in hospital, which are a well-known entity among residents?
Yeah. Burnout is an important issue because especially through this COVID pandemic, we've seen health workers tend to be, really exhausted with the volume of work they have and the lack of control of their lives. And the fact that, they see so much misery in their death that their mind just shuts off. They become callous about it. So the problem is sometimes we also keep in mind that symptoms of burnout and symptoms of depression can have an overlap, right? So we need to, whenever you see a person is depressed, the way you distinguish between depression and burnout is that the typical symptoms of the depression of, it's a constant. See, one of the things I've realized in a person who's going through a burnout, you move him away from the situation, give him a 3-day break, right? He's much better. It is the reasons for this kind of burnout is that there is often these people are either forced to do more hours than they should be doing, or they internally believe they should be doing more because they want to save the world. That causes them to find it difficult to find the balance between, a legitimate work response and. So we've done a lot of surveys here, and we find that junior doctors very often report high levels of burnout. But we also found some protective factors. If the person feels that his seniors are also doing the same thing, and there's a sense of teamwork, right? The person feels part of the team, they're good. If they get the sense that their seniors or people who are looking after them are aware of the difficulties they're going through, and speaks a kind word or finds time for them to take a break, they are able to cope with it. Because medical professionals know that this job is a tough job. They know that. But at the same time, they want to feel part of the team. They want to have sense of control over their lives. So that's how I would deal with burnout.
Thanks, Dr. Arya. Next question is from Sydney, from Prakash Padal. How much percentage of depression cases recur, and how do we prevent such recurrence?
Yeah, depression tends to be a recurrent condition. And many people, in fact, if you look at the stepped care approach of depression, see what happens, there are 2 reasons why depression can recur. One is because the person has a vulnerability to have a recurrence of the same. And I mean recur, the episode itself cleared up, he was well for a period of time, and then the same symptoms came back. This could be because the person has a genetic vulnerability because he's got a family history of recurrent depressive disorder. That tends to be highly recurrent. If you have one episode of depression, and nothing happens after that for many years, you don't have to worry. But if you have another episode of depression in the next couple of years, you can be sure that this will be a recurrent condition. And the natural history is that if you do not treat this and prevent it, the interval between episodes becomes shorter and the intensity of the episodes become greater. So once you make that decision, you have to ask yourself, is this a person who seems to have a genetic vulnerability, in which case he might need to continue antidepressants long term? The other reason why a person can have depression, recurrent depression, is because he did not get better completely from the first episode. Subclinical low-grade depression tends to recur again. So you need to make sure when you're treating a person that the person is completely well. Otherwise, you might need to consider other methods to get the person well, which could include changing your medicine or augmenting the drugs or giving the person some additional psychotherapy. If you have access to interpersonal therapy or cognitive therapies, they are the things that can help prevent depression. In general, I find that when a person is extremely depressed, until they get better, they are not really able to go through cognitive therapy if you have a severe depression. After they get better, that is good because they can use those cognitive techniques to prevent further depressions. I hope that answers the question. If not, you can always email me.
Thanks, Aryan. Next question is from Ajmer by Dr. Preeti Jetilia. Any views on newer antidepressants?
Well, there are, some isomers like, desvenlafaxine and all that. I don't think any of those, those are not considered thing. But there are some novel therapies which is very exciting. There is one inhalation called esketamine. It's a variation of ketamine. It's a nasal inhalation. And what's novel about this is that in moderate to severe, especially even recurrent depressions, it can be used for acute alleviation of symptoms. It works very fast. It works through GABA. It's available in India. It's online. If you look online, you'll find esketamine nasal inhalation. It can be used for depressions which have not responded to normal treatment or people who are suicidal and you want a quick response. So that's one promising and new way of treating depressions. Then, of course, there's transcranial magnetic stimulation, which is different from electroconvulsive therapy. But in primary care, I think that those are things that you have to think in terms of how we can refer.
Got it, Dr. Aryan. Next question is Dr. Srividya Raghavendran from Bangalore has asked, is there any CBT training for primary care doctors?
There are courses which occur if you look online, there are courses, but my suggestion would be if you can read, this book that talked about the new mood therapy and understand that. See, for example, in Bangalore, I'm sure that if you consult the Department of Psychology there, they will be able to help you with how to do this, get some more practice on CBT.
Got it, Dr. Aryan. Next question is what is the best anxiolytic during pregnancy and young age, and are there any exercises to overcome anxiety?
Anxiolytic in pregnancy. See, my personal feeling is that, I tend to avoid anxiolytics unless I have to. And if at all it's for short-term use, right? So the ones unless I'm, a person has got something like a panic attack, I would not even use alprazolam. Alprazolam is a fantastic drug. Works fast and good at reducing anxiety. But any short-acting benzodiazepine tends to be addictive. So if at all you want to use an anxiolytic in a slightly longer term, your options are lorazepam or even better, clonazepam. 0.25 milligrams starting from there and titrate upward. The longer-acting antidepressants, the anxiolytics, are not that addictive. Even then, it's meant to be for short-term use, ideally. But if you find a person who's got anxiety symptoms and you want to help them, an SSRI is one option. The other option would be to give a low dose of a tricyclic antidepressant, like imipramine or prothioidin. They have anxiolytic effects in small doses. But the problem with those is that it can cause dry mouth. The other very good drug, if it's just for sedation, that I find in clinical practice is trazodone. Trazodone 25 milligrams to 50 milligrams is an excellent hypnotic reduces anxiety, and is good from that point. And if you're looking for an antidepressant or any of these drugs, it doesn't cause, see, many of these SSRIs can cause sexual dysfunction for some people, can cause delayed ejaculation and things of that sort. The one which you can use is mirtazapine. It doesn't have any action on sexual problems. 15 milligrams of mirtazapine. Sorry, I interrupted.
Sorry, doctor. Next question is from Dr. Satish Gosavi from Pune. He has asked us to enlighten us about other medico-legal issues in treating patients with psychiatric issues.
Like with every other patient that you see, medico-legal issues arise if the person feels that you have not spent time with them, you haven't understood them, and that you've not been transparent and communicative about what your intentions are. Right, so that's one of the major things to keep in mind. Then the other issues are the issue of consent and confidentiality. So when you're dealing with people's most intimate problems in terms of psychiatric conditions, if you are not able to keep confidentiality and consent and take consent for the things that you do, you'll be in trouble. This is a tricky problem in our country where we don't have a lot of social workers in the social service department to look after people who've got psychotic conditions who will not take care. That is an ethical dilemma because very often doctors will advise patients, just put a little bit of psychotic in the coffee, like whisper it on drops, things like that. Very practical, meant in good faith, but there could be medical legal issues there. So you need to be able to document whatever conversations you're having with a relative on why we did, considering what the issues, to make a justification that this person was, at risk to themselves or to other people.
Next question is, can I take any preventive measurements for anxiety and depression?
There is no real evidence to say that these particular measurements will actually help you. But the things to be able to do is to be aware of the fact that if there are lifestyle issues and career choice issues which can increase your tendency to be anxious and depressed. You're starting to feel anxious and you're starting to feel, you have to ask yourself, for example, if you feel that you need to work very hard because you need to make a lot of money like your friends and you need to have the trappings of success, which is a big car and things of that sort, you have to ask yourself, what is the cost it's going to have on you? So making those lifestyle choices, finding time to balance your life and work, using things that you find pleasurable but not harmful, physical exercise, things like yoga, meditation, mindfulness, these are all excellent general strategies that can help you cope with life stresses. But if you have a vulnerability to get a depressive episode, how much it will work, I can't guarantee, but definitely these things help. Reframing your purpose in your life, the way you deal with others and the way you deal with yourself. And then deciding, I will have to arrange my life in such a way that my goals and my abilities and my levels of stress, I have to keep in control.
Next, I'll combine two questions, one from Dr. Prakash Rao from Pondicherry, another from Dr. Shubha Jairam from Mysore. Dr. Prakash Rao has asked, is depression related to diabetes and thyroid? And Dr. Shubha has asked, are there any biochemical markers for anxiety and depression?
Well, I can ask you this. As far as one of the things that we do and put in the hierarchy, physical conditions, the commonest physical diagnosis we have to rule out when a person comes with depression, especially if he's in the age group and the gender, is hypothyroidism. So routinely you have to do a TSH and TFT, right, and a clinical examination. There is a correlation between diabetes and depression. There are multiple correlations. One of it is that a person who is well controlled and diabetic, like my second example, I told you there was this lady. The second example is the person with a depressive disorder, because her daughter went away, right? The clinician may think, oh, she's just reacting to the daughter's condition. But she's a middle-aged woman, right? And she's got multiple, diabetes, hypertension. There could be reasons why the trigger factor that her daughter going away has triggered off a depressive episode. So we need to ask her for the symptoms of depression. Right? We need to look at the syndrome to see whether she's got at least 2-3 weeks of feeling. She certainly has that. Now, one of the things that happened in her was her blood sugars went out of control. Right. So one thing is there that when you go through a depressive episode, there is a relative insulin resistance and your sugars go out of control. So we've had people who are depressed who we've had to put on insulin to control the depression. And when the depression lifts, the sugars come back under control. So there is a close, intimate relationship between depression and diabetes.
Thanks, Dr. Tharyan. I'll take this last question alone due to want of time. Do we have a primary care treatment protocol for depression and anxiety? Often these conditions coexist with other common non-communicable disease conditions like diabetes.
That's right. So exactly what I was saying, telling. So what we have to do is, first of all, when they come, we have to first see, do they have anxiety, do they have depression, or a combination of the two. In clinical practice, anxiety, depression all sits together. Then there is, I told you, there's a screening instrument called the PSC-9. You can just download, it's available freely on the internet. And if you go through the PSC screening questionnaire, you find that they score anything less than 10, right, 4 to 5 and all. The protocol is, the recommended protocol world over is watchful expectancy. Explain to them these symptoms are there. Give them suggestions on how to, like I explained to you, that's the protocol. Once they have not got better and they start going above 10, is when you have to think in terms of adding the antidepressant, seeing how the other medical conditions, have they been controlled. Simple things like anemia, all of that can cause a person to have depression. Somebody asked the question of, is vitamin D a cause of this? Vitamin D seems to cause all kinds of symptoms. The person definitely is saying you need to consider vitamin D deficiency, but treating with vitamin D itself may not reverse a person's depression if he's got a lot of cognitive symptoms. The other thing is that another one to keep in mind is in certain people, B12 deficiency can definitely cause a depressive episode. So certainly we have to rule out many of these other comorbid conditions because they can contribute to you feeling poor, feeling tired, weak, that's all. Right? So if you rule them all out, if you find that over a period of a week to 2 weeks they're not feeling better, and if you find that their sleep is getting worse, so they're having suicidal ideas, wishes that they would die, then definitely you should consider treating them. And not with an anxiolytic. Treat them with an antidepressant.
Thanks for such insightful answers, Dr. Pratap. And over to Sheetal for concluding remarks.
Thank you, Dr. Tharyan and Dr. Naveen. Dr. Tharyan, the session was really engaging and interesting today, and thank you for taking time out from your busy schedule. Thank you to all our viewers for attending this session. We request you to share your feedback. It's just a 30-second survey, which will help us to understand our areas of improvement and help us to deliver better webinars in future. Our next webinar is scheduled in May. And to understand and know the topics, the speakers, please follow us on BMJ India on LinkedIn and Facebook. Our past webinars are archived on the YouTube channel, which is Education from BMJ. You can go to the YouTube channel and take a look. This is all we have for today. Thank you once again to everyone and have a great day ahead. Thank you.
Thank you very much. Thank you.
Thank you, Dr.